is an evidence session with Dr Hilary Cass concerning her review of gender identity services for children and young people commissioned by NHS England. And Dr Cass is joining us remotely, and I welcome her to the committee. She was the chair of the Cass review. And we will move straight to questions. Dr Cass, thank you for your time, and I'll go to Ruth Maguire.
Thank you, Convener. Good morning, Dr Cass. Thank you for being with us this morning. Your review is obviously a really detailed piece of work that needs careful consideration. I think we all appreciate that it was based on services in England, but will have implications for how children are treated in Scotland as well, and there's learning for us all within that. I wonder if you could start off by talking about the sort of key conclusions that you would want us here in Scotland to draw from this work in order to do the best for children in distress.
Yes, so I think as will be clear from the report, the main issue of concern for me was the weakness of the evidence base. And that's across all aspects of care. So critically, we need to work collaboratively as broadly as we can, both nationally and internationally, to try and improve that evidence base. And the second piece of learning from England was that firstly, children were being bypassed because they were not getting basic assessments locally. Often they were bypassed straight through to the GID service at Tavistock. But crucially, and I think this is transferable, these young people need a very broad multidisciplinary approach to care because they often have complex presentations, and just seeing them through a gender lens means that they don't get the breadth of care that they need. So I think those are the two messages that apply, you know, regardless of where in the UK or internationally you are.
Thank you, that's helpful. That's French now.
Thank you. Tess White.
Thank you. Good morning, Dr Cass. In relation to the 32 recommendations from a very comprehensive report, is there anything specific in relation to the delivery of services that you believe could apply in a Scottish context? Thank you.
Yes, so I think some of the things that I just alluded to, I mean, particularly in England, we are embedding these services within a broader children's hospital service setting so that there is access to services for young people with autism, with eating disorders, with a range of other presentations, so that they do get looked at holistically. And also, I think both the research and the clinical approach, which is going to be regionalised, should the Scottish Government and Health Service feel that it was helpful, there is scope both to include Scotland within the research infrastructure that we're setting up in England, and also within the regional network where there's the ability to share and support clinical practice. But clearly that's a decision to be made in Scotland. It's certainly something that I think we would welcome in England.
Thank you. My second question, if I may. So you in your opening, and to answer Ruth Maguire's question, you talked about the importance of evidence base and collaboration. A question: how do you feel that certain factions of the Scottish Green Party have actually said that your work is a social murder charter?
I think it's not for me to comment on any political opinion in Scotland. I think my job is to just comment on the evidence as I see it, but if that were to be framed into specific questions or concerns about my conclusions or the work, I'd be happy to answer them.
Thank you, Convener.
Thank you. Dr Cass, can I ask what key conclusions would you want practitioners in Scotland to draw from the review in terms of future provision for gender services?
So I think it's important that young people get a holistic assessment, and that includes looking at all aspects of their presentation and trying to understand the gender questioning in the context of other issues that are happening for them. So one of the problems in just focusing on the gender is, that you can end up giving somebody putting somebody on an endocrine pathway when you haven't addressed the fact that they have undiagnosed autism, they're out of school, they're not participating, there's family breakdown and all those other factors. So I think it's, seeing them as a young person first and understanding the gender distress through that lens. And I think accepting that two things are simultaneously true. Firstly, that a small number of these young people are going to benefit from a medical pathway for their gender distress, but that equally for probably a larger number, their gender distress is going to be resolved in myriad other ways, whether that is that this has been a sort of developmental questioning period that spontaneously resolves, or whether they resolve uncertainty about their sexuality and then their gender questioning resolves, or whether they find that they don't want a very rigid medical pathway but just remain gender fluid or gender non-conforming in the longer term. So I think it's about being open and exploring and making sure that options aren't foreclosed too soon for that young person. I think that's probably the single most important takeaway.
Thank you. Thank you for that answer. Ivan McKee.
Thank you. Good morning, Dr Cass, and thank you for spending some time with us this morning. You've rightly mentioned that the evidence base is a hugely important part of the work that you've undertaken, and clearly that's gained a bit of traction in the discourse following your report. So it'd be good to give you the opportunity just to talk through the approach that was taken in assessing that evidence in terms of the systematic review methodology, and what evidence was included and what wasn't included as part of that assessment, and why. Thank you.
Yes, so the systematic reviews were carried out by the University of York, which was one of a small number of organisations that are commissioned by the NHS to carry out systematic reviews. It was overseen by the head of that department. They looked at a very wide array of papers, well in excess of 200 across all areas, but the papers that have got most attention are the ones that have focused on puberty blockers and masculinizing and feminizing hormones, and there were 102 papers that were included within that search. There's been significant misinformation about those, and I hope that's now corrected in everyone's minds. But just to be clear, there was an incorrect piece of information being circulated that the 98% of those papers had been disregarded and that only randomized controlled trials were included. Both of those things are wrong. There were no randomized controlled trials, but there were still 2 high-quality papers and some 50 moderate quality papers. So overall, 58% sorry, something over 50, but anyway, 58% of the 102 papers were included within the analysis because they were high or moderate quality, and those papers included a whole variety of different studies, mainly what's called cohort studies, where you follow up and compare groups or look longitudinally, and they're not randomized controlled trials, but they're still accepted as good evidence if they're conducted well. The significant weaknesses in most of the literature were that, frog in throat. The significant weaknesses was that the follow-up periods were not long enough, that there was significant loss to follow up. So you started off with a larger sample, and because significant numbers fell out during the course of the study, it just made it hard to draw conclusions, that the comparison groups weren't appropriate. So it was a very poor literature compared to most other literature, including in children's healthcare practice. So that was quite striking. And the evidence for the efficacy of both puberty blockers and masculinizing and feminizing hormones was weak, and we are still unclear about potential adverse effects. And if the committee wants, I can say a bit more about puberty blockers, because that's been a source of contention, I know.
Yeah, I think we'll come on to that in follow-up questions. Thanks very much. So that's great, because you've kind of answered some of my supplementary questions as well. So it's true to say that this statistic of supposed statistic of 96 or 98% of the evidence being ignored is A, wrong, and B, the evidence that wasn't included, which sounds to be a bit less than half of it, wasn't included because it wasn't a robust enough methodological approach to be included in the work that York University carried out. That's good. And then the other point I was going to ask about was, how does this compare to methodologies as applied in other areas of paediatric medicine? But I think you've answered that by saying it significantly falls short of what you would see in other areas. I wanted to move on and just ask you about how do we fill those gaps? So what research is underway at the moment? Is it sufficient? What else needs to be done? How long is it going to take for us to build up an evidence base that allows us to address these questions more robustly?
Yeah, yes, and I just absolutely on the last question, just to say there has been the question of, have we set a higher bar for this research or for this systematic review, and we absolutely haven't. I think, in terms of the bar we should set, these young people should get the same standard of evidence in their care as every other young person. So just to say that. So where we are in England, there is a puberty blocker trial being designed that will have obviously involvement from service users, but the lead investigator has been appointed, and a group has started to come together to think about that. There is potentially going to be some international collaboration on that. But I feel that we really need every young person who walks through the door, ideally to agree to be part of some kind of study and follow-up, because it is just important for us to understand what happens to the young people who do not go on a medical pathway as those who do, understand what aspects of care, both medical and non-medical, were helpful for the whole group. And that does mean following young people up into adulthood, including those who go on a medical pathway. Obviously, we can't compel anybody to be followed up into adulthood, and a lot of that is about rebuilding trust with young people so that they wish to be part of a study into adulthood to help the young people coming behind them.
That's great, thank you. And just to be clear, what questions would you hope that the research and future evidence would give us the answers to?
Yeah, so we want to understand if there is a small group of young people who do benefit from puberty blockers. We also want to understand what any potential negative effects there might be on that, particularly for broader brain development and psychosocial development, and bone health and other physical health indicators. And we want to understand more about which young people may benefit in the longer term for going on to a masculinizing or feminizing hormones. I mean, the real challenge is that young people's sense of self and gender identity continues to evolve into young adulthood, and we don't have an accurate way of predicting who will have a long-term stable trans identity. And so the more we're able to be really clear about who has a successful long-term outcome and who has an outcome that doesn't meet their aspirations, the better that will be. And we also need to understand what are the things that matter in the longer term to those young people. So it's not just about can you successfully achieve a sort of medical transition? We know that we can do that, but are people in the longer term are they participating? Do they have a job? Do they have a partner? Are they happy with their sex life? Are they happy with are they psychologically well? All of those things are important.
So that would be looking at physical and mental outcomes from a health perspective. Yeah.
And social outcomes, yeah.
And social, and that would obviously also look at people that chose to detransition at a future stage as well.
Yes, and I think there's been anxiety about, looking at, the trans community as being concerned that we're looking at detransitioners to say we shouldn't be giving gender affirming care. I think the important thing about understanding about people who do detransition is what were the factors that led them to detransition? Were there earlier signs that this may not have been a successful pathway for them? And those are things that you can then build into the equation that you discuss with somebody coming through, so that they know, what the likely risks are for them as an individual. It's the same as any medical intervention where you look at somebody who has a less successful outcome. You then explain that to people who want to undergo that same procedure to inform them. That's not telling them they can't do it. It's saying these are the risks that we're aware of.
That's great. Thank you very much. Thank you.
Thank you. Emma Harper.
Thank you, Convener. Good morning, Dr Cass. Thank you for being here this morning. I'm interested to hear about one of the recommendations about how young people should remain within a service from the age of 17 to 25. The recommendation says that NHS England should ensure that each regional centre has a follow-through service for 17 to 25-year-olds, either by extending the range of the regional children and young people service or through linked services. So I'm interested to hear about how that recommendation means that these young people should stay under the care between the age of 17 to 25, and how would that work in practice? Because I think there has been some misrepresentation that says that means no one will be able to transition before that age.
Yes, so yes, there's been a lot of misunderstanding about this recommendation as well, as you rightly say. So the reason we propose this, it's in line with other aspirations that NHS England has for longer term services for young people, both mental health, cancer, and it's about continuity of care. So the worst possible time, in a way, to transfer services is when you're at a critical point in your gender transition around 17 to 18. And we know that that's been a high risk time when young people get lost between the children's and adult service. There are problems in managing their medication through that period, and switching care providers is challenging. It is also a time when we lose data, which is important if we're trying to get better long-term data. So the idea is to provide continuity through for those young people who are already in the service. It doesn't, so if you are already over 18 when you get referred, you would still get referred to existing services. You wouldn't come through that service. At the moment, it's specifically being set up to take people who have started through when they were younger, to give that continuity of clinical care and also follow-up data.
And just to pick up on what you said about misrepresenting what was either in this recommendation or other parts of the report, you earlier talked about a holistic assessment for young people, for the whole process. And one of the comments we have is that this recommendation is based on dubious science. So it's just to pick up on to I suppose solidify the advice or the recommendation that you've put forward around a whole process for young people right up until the age of 25.
So sorry, the bit that you think is that has been said to be based on dubious science is having a holistic assessment.
No, well, really about the whole part of the whole wider recommendation about helping support young people right through the whole process. The information that we have here says it was based on dubious science. So I'd be interested to hear how. Is that one of the misrepresentations of the report?
So I think the misrepresentation was that we said that that young people would not have to transition at this vulnerable time between, meaning transition between services, and it was taken to mean that they wouldn't have to transition, meaning a gender transition at this vulnerable time, and that was a misreading because the term transition is used to describe the move from children's to adult care as well as gender transition, and it was taken to mean we were saying that children should not go through a gender transition at that time. That wasn't what we were saying, and I think it came under the heading about transition, and a section headed transition, service transition. So that was a misreading. I don't know whether that helps.
It does help, actually, the power of the correct words. So, yes, thank you.
Yeah.
We'll now move to Sanders Kulhani.
Thank you, Convener, and declaration of interest as a practising NHS GP. Thank you for joining us, Dr. Cass. I have grave concerns over the use of puberty blockers for children given the paucity of evidence, and the early intervention study did not demonstrate benefit. And I do feel that ideology and dogma has no place in medical treatment. So given that you stated young people's gender identity is fluid with no hierarchy, do you feel there is a point of age where it becomes more fixed?
There was a study released around the time that the report was in press, which showed that gender discontentedness was relatively high from age 11, and it continued to drop sequentially into early 20s. So it's really, really difficult to know when exactly the sweet spot is, when somebody's not going to be, somebody's gender identity is not going to be continuing to change, and when's the best time to commence an irreversible treatment. I think the thing that we were quite struck by was young adults who we spoke to as part of the engagement process, and also through our qualitative research. they said that they wish they'd known there were more ways to be trans than just a binary medical transition, and you can be more fluid. You don't necessarily have to go down a medical pathway, although some will. And their main advice to their younger self would be, you know, it's not urgent. You don't have to rush. Although they said it feels urgent, and their younger self probably wouldn't have taken too much notice of their older self. So that's the dilemma that we all face.
I mean, certainly the things I believed when I was a child is very different to the things that I believe now and what I feel is important and not. But recommendation 8 in your report states that we should be looking to prescribe medication at 18, with your recommendation 6 stating that we need a trial. And so I suppose, you know, my question is, if it is given below the age of 18, do you feel that there is a point where, or if it's appropriate that this could happen without parents' knowledge, or do you feel that 18 is the point? And also, given your last statement, why did recommendation 8 say 18?
So largely because we don't have, my remit doesn't extend beyond 18, and 18, as you know, a young person is considered to have capacity at 16 unless we have good reason to think that they don't. So it is hard to make a legal distinction between a 16 and 18-year-old in terms of capacity. When I thought about consent, the challenge is not so much about capacity, but the other elements of it, which is the clinical judgment to offer a treatment, which, as you know, we all bear responsibility for treatments that we offer, and knowing whether that is the right treatment for that individual. And secondly, the information that we give to inform consent about the risks and benefits, which again is weak. So you know, legal cases have obviously focused on competence and capacity, but you know, those are the other challenges, those other two pillars of knowing whether we're giving the right treatment to the right people.
I mean, certainly Gillett competence can be from 13 onwards, and that's why I was asking about parents as well. So do you feel that we are able to use Gillett competence in this treatment pathway? And if we can, should the parents be aware?
So the Tavistock avoided treating without parental consent and engagement, and everything we know about outcomes in young people is that they thrive better with family support. So I think I would have severe reservations about a child who was put on this kind of pathway without a competent adult supporting that decision. The Dutch protocol, which the Tavistock was supposed to be adhering to in its service spec, specified parental support and for the decision. So I think that should stand.
Thank you. I have also got real concerns about private treatment. Throughout your report, you talk about an MDT approach, multidisciplinary team approach, and in fact that is your recommendation 9. So should a single private practitioner be prescribing medication, and is it appropriate for this to occur?
I have really deep concerns, like you, about private provision. By de facto, based on the recommendations we have made, that will not be meeting this standard, and I feel that does put young people at considerable risk to not have the level of assessment that we're describing.
Thank you. My final question, if I may, Dr. Cass. Regret and detransitioning is an important area What has your research shown, or has it been able to show how many children experience regret? And seeing as you've said that puberty blockers are irreversible, what do we then do with children who do face that issue?
Okay, so the bit that's irreversible, that we know to be irreversible, is some of the effects of the masculinizing and feminizing hormones. We don't know the percentage that detransition or regret. Largely because the follow-up has not been long enough, and also because those who do detransition or regret don't necessarily come back to the NHS, and they frequently, sorry, excuse me, I don't know, I've got a frog in my throat this morning. They often don't come back to the clinic that they originated from. So that is a significant problem. But I think it's more subtle than that, because for example, I spoke to a young adult who started transition very early, male to female. She's doing well. She had puberty blockers at the earliest stage. She had feminizing hormones at the earliest stage, and she passes very well as a woman. But with hindsight, she knows she was a boy with intense internalized homophobia and was gay. But at this point in her life, she's clearly not going to detransition, so she wouldn't show up in regret or detransition data, but thinks that maybe this was not the right decision to have made. So, I mean, there will be people who are living a good life, but may, with hindsight, have made a different decision, and that's much much more subtle. There are also people who are living their best life, having gone through a medical transition, and for them, the costs and side effects of treatment, are are worthwhile compared to what it would have been like to have to live their life within their birth registered gender. So, those sort of subtleties are really difficult for us to get under the skin of.
Thank you.
Thank you. We'll move to Gillian Mackay.
Thanks, Convener, and good morning, Dr. Cass. Do you believe, and does your research show, that puberty blockers or gender-affirming hormones could be the right intervention for some children or young people?
Yes, we think that certainly masculinizing and feminizing hormones could be the right treatment. We don't know which young people those are. Puberty blockers, it's much less clear what the indication is. I'm not sure whether the chair would like me to just say something about what we do and don't know about puberty blockers and what the various indications.
Yep. Yes, please.
Yeah. So the starting position as to why puberty blockers were introduced, because previously you wouldn't start on a medical pathway until you were 16 plus. And this was because the adult consultant who moved into the Dutch clinic had seen poor outcomes in adult patients and felt that one of the reasons is that they weren't passing, and that was having adverse psychological effects. So she reasoned that if you blocked puberty from early, you wouldn't get particularly the irreversible pubertal changes that birth-registered males get, where you will get facial hair and drop your voice and so on, and that will always make it hard for you to pass. And the second thing she reasoned was that it would buy time to think. So going through those indications, there is no evidence that it buys time to think, in that the vast majority of those who go on to puberty blockers do then go on to masculinizing and feminizing hormones. So it may be that it is altering the trajectory and making it less likely that once you start, you will reconsider the options because you haven't gone through your own puberty, you haven't gone through that psychosexual development pathway. The other aspects that have been looked at is, does it improve your body image? Does it make you less dysphoric? And nobody, not even the original Dutch study, showed that to be the case. And then the other thing is, does it improve your psychological well-being? And although the original Dutch study found some weak evidence of that, the English study did not replicate that. And no other study has really replicated that. So that leaves us with one specific indication, is that they may be helpful, particularly for birth-registered boys, birth-registered males, to prevent those irreversible changes. But one of the downsides of this focus on puberty blockers, which have become almost totemic for being the way to get on to a treatment pathway, is it stopped us looking at other ways of managing young people's distress during that time when they're working out what the right pathway is for them. And so we haven't looked at known evidence-based treatments for anxiety and depression, such as psychological support, or even, medications for anxiety and depression that may be just as effective or more effective than puberty blockers. I don't know if that all makes sense. So it's being really clear about what they're for and for whom.
That's great, thank you. A range of trans organisations and people have said that the report recommendations and the narrative surrounding it give the impression that transition would be the worst outcome for a young person. How would you respond to those who get that impression from the report?
Yes, so for somebody who is going to have an enduring long-term trans identity, medical transition is a really important option, and one from which many people do benefit. The risk of starting that transition at a time when somebody is still developmentally labile, is still in the process of development, is that you give the treatment to the wrong group of people. And the reason that is a negative outcome is because medical transition does not come without costs in terms of effect on sexual function, fertility, our knowns and unknowns about long-term bone health risk, the limitations of surgery. All of those things are costs which are well worthwhile if you have a long-term stable trans identity, but it's a high cost to pay if in the longer term you don't. And so picking that sweet point where, as I said, where you have a high level of certainty that you're giving the treatment to the right people is very important. And the group that we have least understanding about is the group that we are most commonly seeing now in clinic, which is birth-registered females who are presenting in adolescence, for whom there may be a range of other factors driving their gender-related distress.
That's great, thank you. And just one final question. You mentioned earlier in other answers about research. What does good research in your view look like in this area? And do you think it's important that trans and non-binary people are involved in all stages in co-producing that research?
So the answer to the second question is straightforward, yes, and that's clearly built into any research and will be built into this. But we need well-designed studies with adequate follow-up and with really clear comparisons with other kinds of treatment options, and that's what's been lacking from from previous research. The team is thinking already about the most ethical and acceptable ways to do that, and there will be very careful engagement with service users.
That's good. Thanks, Convener.
Paul Sweeney.
Thank you, Convener, and thank you to Dr Cass for your contribution so far. I just wanted to look at the wider balance of harms in this area. We've noted the average wait for referral to gender, or from referral to seeing someone at a gender dysphoria clinic, can often be over 4 years. And in that time, there may be, significant distress, physical, psychological, social, and that may include self-medicating, with hormone replacement drugs. I'm not sure about puberty blockers, how accessible they are. And obviously that can introduce unregulated harms beyond, say, the practice of bridging prescriptions. So I just wondered if you could maybe comment more on what observations, what evidence you've been able to see about that broader practice or behaviour of self-medication.
Yes, I mean, we haven't had any way of systematically understanding how much that's going on, but clearly it's happening, way more than we would wish. I think, as we all understand, the thing that is driving this is major shortfalls in children's mental health services. So young people are in a state of distress and anxiety. They are not getting any support for that or any other aspect of their presenting problem often, and they only have available advice from the internet or from peer support groups. And so it's inevitable that they're going to, take what we would deem as higher risk actions, and I can understand that because they're often in a sort of a situation where the care provided by the health system is failing them, and that's a system failure that's related to workforce and all sorts of things. But I think there is another big problem, which is fearfulness amongst healthcare practitioners. So these young people are more disadvantaged than other similarly distressed young people, certainly in England, because people have been bypassing them. Somebody comes and says they're gender questioning, and health professionals feel nervous because they don't think they've got the skills. They're worried about the toxicity of the debate. They're worried about doing or saying the wrong thing. So they pass them straight through to the GIDS waiting list. And, the areas that they would have been able to manage because they've got all the skills to do so don't get treated.
Okay. Do you have any thoughts about how best to remedy that?
I think I think it's starting already in the new centres in England, in that now that practitioners have started seeing young people, they're really clear that these are the same young people that they're seeing in other clinics. There's because there's been concern about starting that new service. And I think it's about building confidence. I mean, when I was registrar for the Royal College of Paediatrics and Child Health some 15 plus years ago, we were really worried that we weren't going to be able to recruit paediatricians because they were so scared about safeguarding. And you were in a situation where it was catastrophic if you made an error in either direction, overdiagnosed or underdiagnosed. The research was poor, there were no guidelines, and there was very little training. And the way we remedied that was with much better research, much better guidance, and really clear training and supervision. And that turned it round, and it became an interesting area of practice. And that's what we want to achieve here. A lot of it is about building confidence, because professionals do have the transferable skills, and they just need to know that these are the same young people with the same hopes and aspirations and anxieties as most of the rest of the people in their clinic.
Can I just pick up on a point there, Dr. Cass, in a response to Paul Sweeney, when he was asking about unregulated access to to hormonal treatment or to puberty blockers. Was I correct in picking you up saying that it's happening way more than we would wish, that
Yeah.
children and young people are accessing those medications in an unregulated way?
Yeah.
Okay, thank you. It was for a point of clarity. Thank you. Ivan McKee.
I think I've covered all the issues on research follow-up when I did the earlier questions.
Carol Morton.
Thank you. Thank you, Convener. Thank you, Dr. Cass. I want to just explore, if you don't mind, a couple of questions around the approaches to gender care in young people and the move. Perhaps you described it as the dominant model of sort of gender affirming. And you talked about clinicians feeling pressure to simply affirm children, and that could lead to diagnostic overshadowing. For example, you've touched on mental health issues and they've been missed. So I suppose my first question is how do you think a conversion therapy ban would affect that situation, and could you advise how we might go forward with that to ensure that we do give children that protected time to look at this issue?
Yes, this one's a big challenge, and all I can say is I'm glad I'm a doctor and not a litigator, because it is a really difficult problem. You know, everyone should be protected from conversion therapy. It's a completely unacceptable practice. But the challenge of, because in thinking about the legislation, the issue has been about intent. And if a therapist engages with a young person and they change their views about their gender identity during the course of that therapeutic relationship, and then they subsequently say it was because the therapist had an intent to change their gender identity, that puts the therapist in a difficult position, because how can you legally determine intent, and that anxiety, the anxiety that you may be the test case is making clinicians even more anxious potentially about working in this area, and we don't want to do anything to frighten professionals off from working in this. So walking that path is very difficult. I guess the only thing I would say is that no credible professional body would support conversion therapy. So if any practitioner is deemed to be practicing conversion therapy, it should in the first instance be a matter for their professional regulator before it would be a legislative issue. But I don't know how we get that balance right of protecting people from conversion therapy and not frightening therapists who are just doing their job and having an appropriate exploratory conversation with a young person.
Thank you. That's helpful. It is one of the issues I think that ongoing we do need to get right for both the clinicians and the young people, of course. I wonder if you could just give us a little information. One of the things that has been of interest is about the people presenting at the clinics who are same-sex attracted, and how we make sure that we do have that space for those young people. You mentioned a case earlier on in the session where someone perhaps did reflect on what had happened. And if I take it in context of a conversion therapy bill, do you think that we need to take that apart and look at a bill that deals with conversion therapy in terms of sex attraction and trans identity? Is that something we should consider?
Yeah, I think we do need to. There are a very high percentage of these young people are same-sex attracted, and so you can see how the two things could get conflated. And I guess this may have been naive, but one of the things that I was surprised about in conducting this review is how much homophobia there still is, as well as transphobia. So So we do have to, support people in being able to express and understand their sexuality, as well as their gender identity.
Thank you. I have just one last question that has been raised with us, and it was around the including someone with trans identity in one of the reports that you in the review team. Was that something you considered?
Sorry, say again.
Why there was no trans people included in the review team?
Yes. The review team was very small. There were only 4 or 5 people. So whilst, we weren't specifically excluding trans people from the review team, but we didn't have anyone who applied. We had, in a way, I think it's hard for a person on a team to be a sort of tokenistic anyway representative of the whole community. What we did ensure is that we had a very wide engagement. So we spoke every 4 to 6 weeks to the main trans advocacy groups. We had listening sessions. We had with service users. We had 18 focus groups with young people. We had roundtables with the support and advocacy groups. We had qualitative research that took account of both young people and young adults' experiences. We also consulted internationally, and so we made every effort to incorporate service users' voice as broadly as we could.
That's really helpful. Thank you very much.
Ruth Maguire.
Thank you, Convener. Dr. Cass, I wonder if I could just go back a little. You spoke about fearfulness of professionals in discussing this area, and then I know in answer to my colleague Carol Mochan around the issues of conversion and professionals having space to explore options with children and young people. You said research, guidance, training and supervision were the answers. Is there anything further? I mean, I know you'll have had personal experience of the heat and noise that surrounds this topic. I just wondered if you had anything further to add on that.
Yes, I think one of the things that was challenging for the Tavistock and the GID service is that they were a single provider, and any time when you have a single provider and you don't have peer review, you don't have the ability to share practice with other centres, that makes it very difficult. And that's why the way we're setting things up in England is that there's a single national provider collaborative where those centres can come together as an overarching structure to support all of the regional centres. And the idea is that it doesn't matter whether you walk into a service in Birmingham or London or Newcastle, whatever, you will get the same standards of care, the same decision making. And that means you have, shared clinical guidance, you have, shared training, the research works across, and really importantly, that you share data. You have a, shared data set that works across all those centres. And that was why I said that if, there was interest from Scotland that your centre became a regional centre, or, although it might not be physically, I can't speak for NHS England or the formal governance or any of that, but being able to share practice, I'm sure, is something that, would probably be welcome on both sides.
Okay, thank you.
Sandesh Gohani.
Thank you, Convener. Dr. Cass, I know that adult services was outside of your scope, but you did mention them, and in point 1931, you stated that there was an expectation that patients would be started on masculising, feminising hormones by their second appointment, which was a concern given the complexity of presentations. Did your research show anything similar with children's services?
I know that in the past there have been children and young people who have started on treatment relatively quickly. There was variability between the different, teams within the GID service, but that was certainly not supposed to be the way in which things operated, and I think certainly latterly there was more careful control to make sure that didn't happen. Just in terms of that comment about the adult services, I had a number of people with concerns from adult services who spoke to me, and that was their feedback to me. And given that they were seeing the same sorts of young people, moving through, who had that same complexity of presentation, they had clinical concerns about having to, make those decisions so quickly.
Thank you.
Good morning, Dr. Cass. I just want to pick up on a couple of areas that have already been discussed. Firstly, about the cohort of patients. So obviously the data is showing a huge and a very fast increase in birth registered females, the majority of whom are same-sex attracted. And this is a very different cohort from that looked at by the earlier studies. And the new cohort as well has a much more complexity of presentation. So you've suggested that care should routinely include, for instance, things like screening for neurodevelopmental conditions. I'm wondering if you can tell us a little bit more about this, the change in the cohort, the extent to which treatments had been based on the previous cohort, and what risks there might be around that.
Yeah, well, you've summarised it exactly. If you take, as I said, the research is already weak on the previous cohort and even more limited on this current cohort. So you can't make any assumptions that the original puberty blocker studies do read across to this group. And I think it's important that we consider this newer presenting group in the broader context of what's happening to adolescents in Gen Z more widely. So we know that there are, very high rates of depression and anxiety. There are stressors that previous generations didn't have growing up in terms of social media and expectations on young people that arise from that early exposure to pornography, and we don't understand what any of those do to how you might present your distress. And certainly for some young people, that distress or feeling that you don't fit the what you perceive to be the expected gender norms may manifest through questioning your gender identity, and that's why we really have to take this as a new cohort, not rely on previous research, and try and work with young people to help them unpick all of those things that may have led to that gender distress. I think one of the things that's been somewhat lost in the debate is that there's a really close mind-body interaction in, that interaction between mental health and how you physically manifest it, and unpacking that is really complex and difficult and has to be done very carefully.
Thank you. And just on detransitioners, if I may. We need to close them. I'm afraid we need to finish by 10 o'clock this session. Can I thank you, Dr. Cass, for your attendance today and for the information that you've given committee. I'm sure it will help us in our further inquiries as we have other interested parties coming along to speak with us in the coming weeks. So thank you for your time. And I now suspend this meeting.